Well, good morning, everybody. It's great to be here again. I have a nice, much shorter speech now than I did yesterday, thankfully. Technology that offers healthcare providers education through the use of simulation is rapidly expanding and has resulted in improved patient safety and provider competence. Perhaps no one has been more instrumental in this movement than our next speaker, Mr. Tor Laerdal. Mr. Laerdal has a Master's of Science degree from the Norwegian School of Economics and Business Administration and has spent much of his professional career in the family company, Laerdal Medical, of which he has been the CEO and is now the chairman of the board. In the last 5 years, he has devoted most of his time to the not-for-profit company, Laerdal Global Health, which provides affordable training to help reduce maternal and newborn mortality in low-resource settings. Mr. Laerdal has been a driving force behind creating critical AAP initiatives like the Neonatal Resuscitation Program and Helping Babies Breathe. Just this year, Laerdal Global Health won the prestigious Index Award for its neonatality collection of simulators. We are privileged to have Mr. Laerdal with us today to tell us about using simulation to improve patient outcomes and optimize healthcare processes. But before he begins his presentation, I have the distinct honor of presenting Tor Laerdal as an honorary fellow of the American Academy of Pediatrics. In the 83-year history of our organization, the honorary FAAP designation has been given to only 142 individuals. Individuals are designated honorary fellows of the Academy for remarkable achievements that advance children's health or well-being. Tor Laerdal exemplifies these qualities, and I would like us all to acknowledge him as a member of the AAP. Thank you so much. Thank you so much. Very good. We're going to get our picture taken here. Very good. Great. Thank you.
Good morning. Thank you so much for that very, very generous introduction. I feel tremendously honored to receive this fellowship and to be invited to give this talk. My background is different, as you heard from most others speaking from this podium. I'm not a physician, I'm not a scientist. I represent a company that has had the privilege of partnering with the AAP in 3 different educational alliances. So my perspective will be a more practical one on how these alliances, through simulation-based training programs, are helping reduce newborn and child mortality. Ever since the introduction of modern life-saving techniques around 1960, we at Laerdal have provided tools for CPR training and actively taken part in promoting CPR, starting with Resuscitation, the very first patient simulator. At the golden anniversary of CPR in 2010, the American Heart Association estimated that 300 to 400 million around the world had been trained, and that CPR may have contributed to saving over 2 million lives. CPR has been widely recognized as one of the most significant public health initiatives in the last 2 generations. So are there any lessons learned from this massive training activity that are pertinent to this presentation? I believe there are 5. Firstly, that it takes a system to save a life. Without a well-functioning system, which could be illustrated by the chain of survival, the chances of survival will be significantly compromised. Secondly, that advances in medical science have little impact unless they are combined with efficient education and efficient local implementation. There are now over 100 studies published on the survival of pre-hospital cardiac arrest, all using the Utstein reporting template. They show survival ranging from 1 to over 20%. Why a 20-fold difference in outcome when medical guidelines, training manuals, and equipment in ambulances and hospitals are largely the same? The main explanation is likely to be in differences in efficiency in education and local implementation. Thirdly, life-saving must be made simple to learn and remember. Skills decay in only 3 to 6 months if not regularly practiced. The more complex the skill, the greater the decay. Therefore, in addition to simplifying protocols and improving initial training, the traditional requirements for recertification every second year is for good reason now being gradually replaced by a different regime with shorter, more frequent rehearsals of critical skills. This is often referred to as low-dose, high-frequency refresher training. Fourthly, simulation is a very efficient educational method. This meta-analysis of 182 published papers evaluating simulation-based training appeared in the journal Resuscitation last month, and it concludes, quote, "Simulation-based training for resuscitation is highly effective," unquote. Fifthly, collaboration results in more effective implementation. As early as in the fall of 2006, Laerdal and the AAP partnered in a strategic alliance to advance educational science and resources available to the AAP life support programs. This was followed by a decision of the AAP Steering Committee to transition all future educational program initiatives to simulation-based training, and the launch in 2007 of the co-developed SimNewbie neonatal patient simulator. Other collaborative projects include the pediatric life support scenarios, the education for pre-hospital personnel program scenarios, and simply NRP, as well as numerous other self-directed learning programs, and a number of pediatric simulators developed to support these programs. So you may ask, is patient simulation about high-tech, at high cost, and for high-resource settings? Not at all restricted to that. Patient simulation is about an educational methodology that can be used everywhere. That became evident in 2008 when we were invited to join the global implementation initiative of the neonatal resuscitation program. Every year, about 700,000 newborns die from birth asphyxia, and in addition, an even higher number may be wrongly classified as stillborn, as around 30% of the total of 2.5 million stillborn are assumed to have a heart activity during labor. Close to 99% of newborns' deaths are in poor countries. Very many of these newborns are savable. So, by far the greatest potential for CPR to save lives relate to newborns in low-resource settings at day of birth. What was needed to reach a much higher number of birth attendants, also in rural areas, was a new approach, a culturally adapted course with focus on the few life-saving steps in the first golden minute. What resulted was the Helping Babies Breed program. In collaboration with a program task force, we made this newborn simulator to enable the bulk of the time to be used for hands-on practice. Filled with water, the simulator accurately resembles a lifeless baby and is highly realistic for the defined learning objectives of correctly responding to 3 key questions. Is the baby crying? Is the baby breathing? Is there a heartbeat? At a not-for-profit cost of $50, these simulators can be used in a ratio of 1 to 2 students, and also left behind in the labor ward after the course for regular refresher practice of bag mask ventilation and other skills. There are now over 50,000 of these simulators in use in low-resource settings. In 2010, implementation of the Helping Babies Breed program really took off with the initiative of USAID to establish a global development alliance where also Save the Children and NIH joined as partners. And in 2012, a UN Commission defined newborn resuscitation among the top priority interventions for scale-up to reach Millennium Development Goal number 4 of achieving 2/3 reduction in child mortality. Later in 2012, the AAP and Laerdal were among the founding fathers of a second global development alliance called Survive and Thrive. Among its objectives are to strengthen professional associations in low-resource countries and help scale up also other priority newborn and child interventions. The impact of Helping Babies Breed is being evaluated in several countries. The most significant study published so far was initiated by Dr. Jeff Pearlman and conducted with the Ministry of Health in Tanzania. Here's a brief video clip with Dr. Georgina Mosimo, the principal investigator.
Helping Babies Breathe implementation and monitoring process in Tanzania is led by the Ministry of Health. They selected 8 research sites to study the impact on newborn mortality after the Helping Babies Breathe training. More than 88,000 births were observed over a 2-year period. The results were remarkable.
The HBB results from our research sites, it showed a reduction of early neonatal mortality by 47% from the baseline. And this was very significant in terms of lives saved for those newborns.
The study was published in Pediatrics in January this year, and its very encouraging results has triggered further interest in the Helping Babies Breed program. Note that in addition to a 47% reduction in early neonatal mortality, the study also found a 24% reduction among fresh stillborn. As one example of the increasing interest, Helping Babies Breed 4 weeks ago was featured as a breakthrough innovation for improving newborn health in a report presented by General Secretary Ban Ki-moon to the UN General Assembly. By June of this year, over 130,000 birth attendants in 60 low-resource countries have been helping babies breathe trained. 18 of these countries have national scale-up plans. By end 2015, the finishing line for the Millennium Development Goals, and less than 800 days from now, the goal is to have trained and equipped 1 million birth attendants. If we can capitalize on the current accelerating interest and support, there is good hope of reaching this very ambitious number, especially if the count includes HPB similar courses recently introduced in India and China. And imagine if every one of these birth attendants trained could save 1 life per year. So why this success? Helping Babies Breathe, no doubt, has filled a void for an efficient program to respond to birth asphyxia, the main killer on the day of birth. Here are some comments by Dr. Shadidullah on why the Health Ministry in Bangladesh decided to sponsor training of 25,000 birth attendants, and he is in a conversation with Professor George Little, co-chair of the AAP Program Steering Committee.
There's the medical action plan. There is the educational theory and practice, which includes a dyad teaching. And thirdly, there is some very innovative, cost-effective equipment.
That's very crucial, I think.
That's crucial.
Had it been so costly, the mannequin,
Yes.
the bag and mask, and the penguin sucker,
Yes.
it would not be possible for a country like Bangladesh to procure a huge number of these training materials. And the dissemination meeting, the findings, that was so overwhelming that the minister right away said that don't want to see that it's ending here. I like to see that it's being scaled up in the country. And when you have a political commitment, then the thing becomes very easy.
The success of the Helping Babies Breathe program has stimulated the AAP to take the lead role in developing 2 more training programs dealing with the other main killers in the neonatal period: infection and complications of preterm. These programs are expected to be introduced in 2014 and will both also be simulation-based. So, in conclusion, patient simulation is a very effective education methodology. And the AAP Laerdal alliances are putting patient simulation training to efficient use to improve patient outcome in both high and low resource settings. Thank you very much.
Thank you. That was